Welcome to today's meeting of the Health and Social Care Select Committee at London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chair of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure that your mobile phones are on silent. We are not expecting a fire drill, so if the fire alarm goes off, please follow Nikki out of the building. Please keep your microphones muted when you aren't speaking and then unmute to speak, and as chair I will call on those to speak in the meeting. It's worth noting that some councillors on this committee may be using devices to access the agenda and papers for this meeting. Okay, so we'll move on to the agenda. Nikki, do we have any apologies for absence?
Chair, we've had apologies from Councillor Punja and Councillor Nelson West is here as her substitute.
Welcome back, Councillor Nelson West. Your regular appearance here is very welcome, so looking forward to your contribution. Does anybody have any declarations of interest before this meeting? No? Fantastic. So we have the minutes of the meeting of the 25th of February. Are we happy with those? Yeah? Agreed? Fantastic, we agreed them. And item 4 is exclusion of press and public, but everything that we're doing tonight is in public, isn't it? So that's great. Okay, so we come on to our main agenda item, which is our second witness session in our adult social care early intervention and prevention investigation that we're doing. So what I'm going to do is I'm going to pass over to Gary Collier, who's Health and Social Care Integration Manager, to sort of kick off this session, and obviously you guys run the session as you wish.
Thank you, Chair. What they're intending to present to the committee today follows on from the witness session that you had held in last month. What we're proposing to do is actually look at in more detail at two particular areas, neighbourhoods and neighbourhood working, which will be presented by Edward John, the Chief Executive of the Confederation, and then look at in more detail at one of the key preventative services that we identified at your last meeting, which is reablement. Session will also look at the bridging care service, which we didn't touch on at the last meeting, but along with reablement it forms a sort of key pathway out of hospital to enable people to return to their usual homes. And G. Baftia, the Chief Executive of Comfort Care Services, and Edward Subbins, the Head of Home Care for Comfort Care Services, will present on that. I'll suggest, Chair, if you're happy, we'll go to the presentations.
Yeah, I'm very happy, and I'm very happy until we get into questions for you to sort of call on speakers and to sort of manage this bit of the meeting as well. Thank you.
Perfect. Thank you. Apologies, Gary, if I gave you a heart attack for arriving so late. You know Hillingdon crossing the A40 at this time of night, so apologies. Thanks for inviting me to talk about neighbourhoods. My name is Edmund Yarn, Eddie Yarn for short. I do normally get called Eddie. I'm the Chief Executive of the Confederation, Hillingdon. We're a community interest company formed by all the GP practices in Hillingdon. So we represent the GP practices and we support them and enable them to work in partnership at scale with the likes of the London Borough of Hillingdon and with the hospital and with the Community Trust. But we also lead, and I am what is called the SRO, the Senior Responsible Officer for Neighbourhood Development in Hillingdon, from the healthcare sector. And so primary care, as in general practice, takes a lead on neighbourhood development in this borough. So I'm going to go through my interpretation of the outline agenda that Gary set around what do we mean by neighbourhood working, what are integrated neighbourhood teams, and as you can see the agenda up here, and I'll try and go through that, but I'm fully expecting questions, so do feel free either at the end or as we go.
What would you prefer? Would you prefer questions as we go or at the end? I don't mind.
I'm happy to do questions as we go.
Okay. So if people would like to indicate to me if they want to ask questions as we go. Unless it gets too chaotic and then go straight to the end.
Yes. Protect me from chaos, please. Yeah, fantastic.
Okay. I think committee members are feeling like the presentation and questions at the end will work better. So,
fine.
Yeah, we'll do
I'm happy with that as well. Firstly then, what is meant by neighbourhood working? There's a definition, there's many definitions of neighbourhood working. I like this one. It's simply a Googled definition, but I liked it. It is about collaboration. So it's a collaborative approach where local communities and statutory services work together to improve the health and well-being of their population. And I actually think that neighbourhood working, that's pretty much, if that was a label on the tin, that would work for me. We do tend to work in silos within our organisational boundaries. Neighbourhood working is about breaking down those barriers. Importantly, it's about trying to wrap the care around the patient, indeed the resident, in terms of the people of Hillingdon. And I think in many ways it's easier to work in a silo. It sets yourself, you're in a box, you're able to get on with your job, you've very clear parameters. It's actually more difficult working in much more of a matrix organisation, much more joined up parts, many more relationships you have to take account of, but actually that is the way that you wrap care around the patient and join it up. So in many ways, neighbourhood working is more complicated for the care providers, but simpler for the receiver, for the patient, and thereby it's actually quite difficult to do, but hopefully a much better experience for the patient. So, I think I went forward too then. So just to then put integrated neighbourhood teams in context. So I view neighbourhood teams as a team of teams. So it is your community nurses, your GPs, your mental health practitioners, your therapists, your social care workers, health visitors, etc. They are organised geographically. So a neighbourhood has a physical aspect to it. It is a geography. And it is about the people in that geography working together at a management level, but also at a day-to-day basis, like I say, as individuals in a team of teams, wrapping the care around patients and residents. The individual within the team stays in their organisation. Their lines of accountability go up through their organisation. But what we're starting to develop in Hillingdon is also a neighbourhood leadership team. So you also have a team working that will come on later. Hillingdon has 3 neighbourhoods in the way that we've configured it. And so you have a senior person in community nursing, a person from community mental health, a senior person in adult social care, senior person, GP, lead clinician. And they actually then work together as a team and have a joint accountability for how that neighbourhood develops and how it performs. So it actually almost gives you 2 reporting levels through your organisation, but also locally into your neighbourhood. I hope that makes sense. So that local leadership team will set themselves a development plan, what they need to change, what improvements they need to make, but also how they can work together to improve efficiency and speed up access to care for their residents. They work on the basis as well as there being no wrong front door. So this is the idea to help prevent if you like, I heard a hospital consultant just this morning call it the ping pong effect, where you're bounced around. You go to your GP, the GP refers you to the consultant says, well, actually, you need to go back and get this test first, comes back to your GP refers you elsewhere. Actually, at a neighbourhood level, that consultant should be talking to the other team directly, sorting out if that is the correct place for the patient to be, and then informing the patient and making the referral instead of the patient having to ping-pong back to the GP. So that's a sort of anecdotal way that it should improve both the efficiency, but that idea of there being no wrong front door. So as I said, in theory, I can talk here to you and hopefully try to make it sound simple, but it requires complex working behind the scene in order to simplify things for the patient. Where are we? The little graphic on the screen is a North West London Integrated Care Board version. It's a maturity index. I don't know how things are in the world of the council, but healthcare loves a maturity index. Hillingdon's at about level 3 in this. Now, any index like this is relative. Hillingdon is probably the most advanced. In fact, I would say it's not probably, it is the most advanced borough in North West London of the 8 boroughs in how we're developing neighbourhood working. So we're in the middle, and in some ways I think we've done a lot of the groundwork and really now want to start reaping almost like, if you like, benefits realization from the groundwork we've put in. But there's still a decent journey ahead of us. I put on here just some opportunities in very general, at a very general level. I do think we have an opportunity in Hillingdon to invest in neighbourhood hubs, in local infrastructure. I think in particular with the development of the hospital, we are trying to push quite hard to see neighbourhood development as a complementary aspect of that. The new hospital is a new shape, new size, and actually the efficiency and the good work going on in the hospital would be complemented enormously by a different shape and a different size of how things are organised outside of the hospital, and that is neighbourhoods. Certainly, there should be a lot more efficiency gained from working in neighbourhoods. That ping pong, as I've described it for a patient, is actually also more expensive. So getting the patient seen by the right person, the right place, and making every contact count is actually cheaper and more efficient in the long term, in the short term as well, to be perfectly honest. Challenges, I'd say time. I sit here as a manager, thinking, well, I want to make a decision about this, but a lot of neighbourhood working requires a build-up of trust, improvement of relationships. Technically, you can get things done fast, but there's a lot of barriers and custom and practice, and almost like organisational culture that works on. I think just in the last 18 months, 2 years, there's been a huge advance and change in the improvements of how health sector and social care and public health have been working together, for example. But you could have seen what was necessary 2 or 3 years ago, but actually it takes time to build that trust up. and I've put finance down there. And this isn't so much, we want more money. It's just that when things are tight, you protect what you've got. And it's difficult to see that if you join the two things up, the three things up, you can actually get more bang for your buck, because actually you're trying to hold on to what you've got. So it's actually blurring some of the financial lines and joining up services. We do quite a bit with CNWL, with some of our neighbourhood services. We have care connection teams, we have an integrated care home service. Those services take a little bit of money from the CNWL budget, a little bit from the GP's budget, and in fact in one case with the care homes topped up with a little bit from what Keith Spencer can provide us. And by combining those funds, the whole is much better than the sum of the parts, and we can do a lot more with an integrated service. So it's about building up that trust to blur the finances. As things get tight, and I don't need to educate anybody here about how finances get tight, that gets more difficult. So just the challenges. Success measures. I put down on the right, there are KPIs being developed by North West London, key performance indicators around some of the things you'd expect. They range from public health issues like adult and childhood obesity and smoking rates, vaccination and screening rates for cancers, through to admission rates into the emergency department. So right from the public health sector to more proactive care work that we do, right the way through to reactive care and dealing with emergencies. The common issue is trying to move things, what we'd think of as upstream, into the more preventative work, away from the more acute and reactive work. And we also are developing our set of criteria for Hillingdon as well, because what we want to see in the KPIs is particular movement about some of our priorities, and I'll come on to them just in a second. I put on here as well, the point of having measurements isn't that the GPs get measured to within an inch of their lives. They have about 244 KPIs. The hospital similarly, community similarly. One of the issues with neighbourhood metrics is you own it collectively, so that your neighbourhood leadership team owns the health and well-being of the population, which is really important, and that also starts to break down barriers, because it's not just my job and my target, it's our job and our target. Just some examples of neighbourhood working. I'm really pleased to say that in Hillingdon we've been working to the concept of neighbourhoods for quite some time, and it's not a fashion and the latest thing as far as we're concerned. I know it's a major national agenda now, working in neighbourhoods, but we've been working on a programme since 2017. I think it is now accelerating, and I'm pleased to say we have care connection teams, which are joint teams with community matrons, GPs and social prescribers from H4All. They're looking at the most vulnerable people still living at home in the community, but are what we might call rising risk. So at any one time, there's about 4,400 patients in Hillingdon out of your entire population, 2%, something like that. They will make up 50% of all non-elective admissions. So a huge disproportionate amount of work that goes on. If we can do care planning, identify those between the GPs and the rest of the team, put a care package around them, the community matron then supports them to stabilise in the community where they live. We find that the admission rates into the hospital are reduced by 41% for the 6 months after a patient has been with the Care Connection team compared with beforehand. So it's a small investment with a big reward. Again, it's organised geographically, the community teams, the GPs and the social prescribers. We have paediatric clinics where the paediatric consultants come out, work with GPs, work with practice nurses on particular clinics. Again, organised as neighbourhood, 3 ways around Hillingdon. They don't only see patients out in the community, they basically move 1 in 4 of their clinics out of the hospital into the community and rotate them around the neighbourhoods. But in working with the GPs and the nurses, they upskill the GPs and the nurses, prevents further unnecessary admissions, and actually gets both the paediatricians and the GPs working to the top of their licence. We have a care home service I've mentioned. We have a same-day urgent care service, which is based around 3 neighbourhood hubs, the most mature of which is at Pembroke, the Pembroke Centre on Pembroke Road, which I've just come from. They're trying to improve same-day access to GPs, so that there is a place where when the GP appointment book is full, they can book an appointment on the same day still for patients that need urgent attention. So it relieves pressure on the GPs, gets a patient a necessary appointment, but also has the impact of preventing the patient rocking up at ED or the urgent treatment centre. So it's actually preventing an unnecessary hospital episode from happening. So just some examples of what we're doing at the moment. In terms of the social care team and how we're working with the council, I think I actually said a little bit earlier, a few minutes ago, that how we're working with the council has come on in leaps and bounds over the last couple of years. We work very closely with Sandra Taylor. Some of what we're doing in trying to build up neighbourhood working and indeed neighbourhood hubs, parallel family hubs, and in some ways the concept and how you've been trying to join together some of your services have a close parallel, and actually then looking at how do we join up the health and the social side of things. I think it's a very similar sort of idea at its core. A lot of our data now about how we set our priorities comes from public health. So it's the analysis that public health provide us with Kelly and her team, sitting down with the GP, sitting down with our community colleagues and looking at the priorities. And so when you look at the southeast and the Hayes-Harlington area, the population is very different from the northern neighbourhood with Northwood and Ruislip. And actually the data tells you that. There are some common things across the whole of Hillingdon, but the flavour within the neighbourhoods is quite different. So we get a lot of input, a lot of co-working with the public health team. Are we truly integrated? This is the additional line, isn't it? I think we've got to a stage now where our leadership teams and our plans are quite well integrated. we now have to, I guess, deliver more. We've got quite a lot of services which, if you experience them, will be good, as some of the ones I've listed. But there are, I think we've got a count of something like 140 different commission services. So if I've got 7 or 10 that are working really well, we're at quite a small percentage of the total, but we should be in a position now where we can start to deliver change and improvements more rapidly. So we are on a journey, and we're in a good place in that journey, and relative to other boroughs, we're in a best place on that journey. But is it truly holistic care wrapped around the patient right now? We've got a way to go. I think that's the honesty about it, and I think that is it. So I hope that's a bit helpful.
That was really interesting. Before we go into questions, that was really interesting actually, and I've written down a lot of questions, but I won't ask them all. But before we go into questions, I think it'd be good to have, is that okay, Gary, if we go to the next people? Yeah, I think that makes sense. I know we do the whole questions and debate together. I think that works well, doesn't it? So G and Edward, please tell us what you want to tell us.
Good evening, everybody. My name is G. Baftia. I'm the CEO of Comfort Care Services, and my colleague Edward, who heads up the delivery of the reablement services. So any difficult questions, I'm going to just pass over to Edward.
As well.
I feel that I'm his sidekick. Okay. A little bit about Comfort Care Services so that you understand the context. We are perhaps one of the larger providers for Hillingdon social care services. We provide support for people with LD, learning disabilities, mental health, and older people in different contexts, in different settings: supported living, extra care, domiciliary care, and specialist care. Part of our specialist care provision is reablement care. And bridging care, as was mentioned earlier. So that tells you a little bit about the company and what we actually do. So in terms of no problem. Okay. So what we're going to cover this evening is just a little bit about the context of what we do, the national and local context. A graphic for about intermediate care, so you understand how this all fits together. And then we'll talk about bridging and reablement services very specifically, some of the key success factors that Gary's asked us to comment on, a couple of case studies just to illustrate how we help, and then conclusions. There are a number of challenges that are ongoing, but there are also a number of opportunities that I think that we can take advantage of. Okay? In terms of the national context, the UK government, via the NHS, through the Better Care Fund and the 10-year NHS plan, have prescribed solutions both at a national level and at a local level, specifically to address a number of issues: reduce the pressure on the NHS and hospital bed settings, specifically prevent inappropriate referrals into hospital, and prevent delayed transfer of care out of hospital into the community settings, maximizing integrated community-based services, so really using the community resources to provide as much of the services as possible, and maximize independence in people's usual home, i.e. return them back to the settings that they can live in and can continue their recovery to the extent that they need to. So this mandate, or this requirement of local authorities and the local NHS systems gets manifested in different ways by different organisations. In Hillingdon, we're supporting with bridging care, reablement care, and step-down beds. Step-down beds being part of the overall provision, and also mobile response team support. So these are all services that we deliver under the guise of intermediate care and what sometimes get called reablement care. Okay. So a little bit of a graphic. It normally works from left to right. People are in hospital, they come out, they get reviewed and they get triaged. Some of these patients come into bridging care for a short period of time, then they move on to reablement care, and then they move into their independent living where they've been sort of maximised for independence. Now, it's not always linear. Sometimes people come out of hospital straight into their own homes. Sometimes they go into bridging care. Sometimes they go into reablement care. And down at the bottom, you can see this thing called step-down care. So step-down care is part of the intermediate care facility, and it's something that we've just restarted very recently back in Hillingdon. We had a bit of an episode during the pandemic period where step-down beds were provided, and we would provide interim care in that environment before people moved on to their permanent homes. So there's really three modes of support in intermediate care. I'll tell you about the figures and the details in the next slides on there. So this is a little bit more of a graphic to really explain what goes on. So imagine you're a patient and you're in the hospital. You've been medically optimized. You've been assessed, but the assessment shows that actually you need continued support to be able to live your best life as independent as possible. Now, there's a choice to be made. You can either stay in hospital and all that care and support will be given in the hospital, or you can be helped out back into the community. So really, if the decision gets made that it's best to be done in the community, your recovery continues in the community, then there's a triage by adult social care. They make that decision. They refer the patient into the bridging care service. So once an individual comes into the bridging care service, then it's really about transitioning from hospital setting into the community setting. The whole focus of it is to stabilize the patient, which we then start calling a service user because they're no longer in a clinical setting. So we stabilize the service user there, and by providing personalized support. And the whole idea is to focus on the stabilization so that they can continue on to either independent or into a longer term solution, which might even be reablement care. Typically, a service user will stay in bridging care anywhere from 1 day up to 5 days. Typically, that's the kind of range that we talk about in bridging care. Just to give you an idea, in the last year, we've supported approximately 1,700 patients into our bridging care services, so that gives you an idea of the volume. It's quite an intense business, as Edward will no doubt explain later on. If it's appropriate and bridging care then means that somebody goes directly into their independent living, into their own homes, that's great, that's a real success. But sometimes they go into an extended interim care, which is reablement care. And then the reablement care is really focused on enabling individuals, enabling them to, so this goes beyond stabilizing now, it's about re-enabling them to live independently. It's a temporary support that we give them for up to 6 weeks, and really the idea is to achieve the aims, the goals of the outcomes, and that's independence. And again, we're talking about 1,200 patients that we've supported in services that we've supported in reablement care for the last 12 months. So significant figures. Now, although I've drawn it linearly where everybody comes out of hospital, in fact, in reablement, services also come in from the community itself as well. So we've got about 80%, 20% split, 80% out of the hospital pathway and 20% split into coming in from the community. That's been a recent development, in fact. There's been quite a big focus. I guess there's been a campaign within Hillingdon Council itself to make sure that that community-based services and community referrals come into reablement as well. So we provide support for both hospital source patients and community-based service users. The ideal being that aims is achieved and the individual goes on to back into their home or their long-term care solution. So it might be they go into a home without any further support, any further care, which would be ideal, or they might go into a home kind of environment where they have domiciliary care, ongoing support, or they might go into an older person's home, nursing home, a permanent solution in there. So that's basically the flow through the organisation. Now, I was very interested in what Eddie had to say about the partnership working and integrated care, because this whole model really works around integrated care. As hard as we work in comfort care services, I think we are basically the coordinators and the delivery mechanism of integrating GPs, district nurses, occupational therapists, nutritionists, pharmacists, rapid response people, social workers, all of those professionals come together to provide wraparound care to the patients to enable them to then continue their journey onto independence. So I think one of the key things I would say, a takeaway, is this whole partnership working is very, very key, and we wouldn't be able to do the work that we do without that partnership working. So the next slide I'll just take you through is the key success factors. I think there's an interest in what actually makes it work. As I've mentioned, partnership working is really key. It's very easy to say, and I think I read on Eddie's presentation, it rolls off the tongue, but it's really hard to put together. And it's not hard because people just want to make it hard. It's because people have, they're optimized for different parts of the solution. And actually bringing them together, it actually sometimes means that you have to sub-optimize parts of your organization to make the flow work correctly. And that takes trust, that takes a lot of maturity within organization, and it's taken some time to get us where we are over there. So I think that's really very, very important. And I think partnership working starts when the senior management take ownership, when they give direction and they give the space for trust to be built. So I think that's very, very important as well. And I think with all the stakeholders, there's got to be an ambition to make a change, make a difference in there. So we have partnership working. I think that's very, very important. Leadership from the top, and ambition and willingness to change. And when that comes together, you can really engage with stakeholders. And as I mentioned in the earlier slide, there's lots and lots of stakeholders. I've just mentioned a few of them again here. Clinical, care providers, OTs and physio support organizations, adult social care. Very, very important to get all those stakeholders actively engaged in contributing their part of the solution. The other thing that I would say is very, very important is to map out the end-to-end process, because we all imagine that everything joins up together quite nicely, but actually, in our experience, whereas there's a lot of intention that everybody will work very smoothly together, it actually requires mapping out of the process and ownership of the process. So clear accountabilities, information flow and transparency. Information flow is very, very key to making this work, because as I mentioned earlier on, people stay in our services up to a maximum of 6 weeks. So you don't have a lot of time to get things right. So you need to get things planned the right thing and do the right thing at the right time to be able to achieve the outcome that we are looking for. And actively seeking out what the bottlenecks are within the system and resolving those bottlenecks in a constructive way, not in a way to criticize people, because I really do believe the system wants to work together, but sometimes it's just so complex that we trip ourselves over. So being honest and transparent, identifying where the bottlenecks are, that's a good thing. One of the key things about the factors is staffing. It's not just about recruiting staff, but it's actually a value-based recruitment, because in the work that we're doing, re-ablement is not just about maintaining people in the support that they receive. It's actually about enabling them to give them just enough support that they receive the support that they need, but they actually grow and re-able themselves. So I think that value-based recruitment is very, very important. And the over and above training, which means that this is not just standard training, which maybe home care services, domiciliary care deliver, which we also deliver to Hillingdon, but it's an additional part about making sure that we are supporting our service users to rehabilitate and develop, reskill themselves to live independently. I think that's very, very important. And one of the key things that we've also identified is being responsive to fluctuations in demand. Because literally, especially in the winter months where there is bed blocking going on, you can go into black very, very quickly, and the whole system has to mobilize. Well, whilst we might be running, I say at 120%, then you have to exceed it to 160% to be able to allow the flow to happen again. So that fluctuation, being responsive to fluctuation in demand, is very, very important. And then the other thing that I think that was really done very well in Hillingdon is that the project was resourced correctly when it was being piloted and it was being mobilized. There was a lot of commitment being made. It was resourced correctly, and then the ongoing delivery was resourced correctly as well. So there's an activity that goes on project, and it was an immense amount of resource that was actually put in to make it work well, and then it was fine-tuned over the last few years, which means that we were able to put a lot of throughput. Okay. Some of the key success factors, I think the key takeaways on here is that yes, we have many KPIs. I think Gary holds us to account with lots of KPIs, and we have regular discussions on it. But I guess the volumes speak for themselves. In terms of bridging we've through the 24-25 years, year 24-25 until the end of March, we will have seen about 1,700 service users. That's a significant number. 24% of which need no further support needs. So they go straight out of our bridging into their long-term, usually back at home. 53% of those go into reablement, so they need a further support. And 8% go into long-term care, and then 10% go into hospital readmission. So nobody likes the situation where hospital people are readmitted to hospital, but this 10% doesn't necessarily mean they were admitted into the hospital for the same reason they came out. It might be some other ailment that they've got. So although that 10% is a large number, I think it still is significantly less than otherwise they would have been in. Our average stay for our service users within bridging is about 6.4 days. That's been quite an improvement from, I think it was about 9 days then? Yeah, it went up to 9 days, because, not necessarily because of the bridging itself, but because of the blockages in the system. And some recent commissioning work that's been done by the council has meant that we were able to get the flow going again, and the average number of hours, average number of days in bridging has reduced down to 6.4 days. So that's pretty good. In terms of reablement, almost 1,200 service users have been through, or will have gone through by the end of March, with 87% aim achieved. 87% aim achieved is a massive achievement. I think that's really a lot of hard work, and a testament on how, when you fine-tune the system, it can actually move forward to 87%, and 30% is other, which includes some hospital readmission and things of that nature. Average stay is 28 days. The maximum time allowed under the KPIs is 42 days, 6 weeks. But the average time that they stay with us, our service users stay with us, is 28 days, which is only 67% of the time that's actually allocated. So we are getting better and better and better at predicting when a service user will be able to come in, what kind of support they will need, and then actually help them exit our care delivery back into their permanent support needs. What else is there to be said about that? I think, I guess the next part of it is just a couple of case studies. So there's two case studies here. One case study is Mrs. A, 78 years old, went through some quite significant surgery with a hysterectomy, and was referred into our bridging care support to continue on the recovery process with washing, dressing, meal preparation, and improving mobility on there. We work with the rapid response team, occupational therapist, and GP to provide wraparound care and support to Mrs. A. And a bit of a typo there. Mrs. A continued to recover at home, and actually the 2 visits reduced down to 1 visit within 10 days, and within 15 days was fully independent. So I think that was a great achievement. If it wasn't for the bridging and the reablement care, that would have meant that Mrs. A could have stayed, or would have stayed, in a hospital setting, which is probably the least place that she would have recovered. So that was a very good example. Another example is Mr. B. Mr. B went through bridging and reablement, 92 years old, had a fall and had a fracture. Mr. B then was supported through bridging to stabilise into reablement towards independence on there, was supported by reablement physio, district nurse and a GP. And the interesting thing was Mr. B was actually bedbound for a period of time, recovered through the bedbound, regained mobility. During that period of time was supported with personal care, with meal preparation, living at home, and learning how to reuse the stairs, which was all done by our staff members. And following that reablement process, actually the family took over, providing continued support. So actually there was no further care and support being provided by the health or the social care system. And we received ever such nice notes of thank you for in both cases, because I think people really appreciate the care and support that they get in the home, in the environment that they want to actually recover in. Okay, so my last slide is about conclusions, challenges and opportunities. A few stats for you. The Hillingdon Intermediate Care System achieved actually an impressive 87% of AIM achievement rate, really driven by effective partnerships. We've got a robust working model, as you've seen, and recent pathway enhancements. And recent pathway enhancements is the fine-tuning I was talking about, learning from each year's worth of experience and adjusting the flow accordingly. The Hillingdon ASCOF for outcome measures for Hillingdon Council themselves for the short-term services measures has improved from 80% to 89.1% in 23-24, which is the latest published data. That was a 9% improvement, as compared to a 79.4% national average and a 77.6% London average. So that's actually quite significantly higher than the London average. So I think that's a testament to how well the process is actually working. And I do believe, Gary, you've got the more recent numbers for this coming year. Perhaps you can explain that one in the questions. So it's a complex system. There are some challenges. There are some ongoing challenges. Actually ensuring timely resource availability to meet increasing demands, and that's really that fluctuation I was talking about. It takes time to mobilize, bring new staffing in, training new staffing to be able to address the actual demand. Recruitment and retaining skilled professionals. We do recruit people, we skill them up, and then many of our skilled professionals leave to join the NHS. So I guess it's best to keep them in the system rather than lose them entirely. But that is an irritation at times, shall I say. And what we're seeing now is that the kind of referrals we're getting in, especially from the community, are increasingly complex. So they're more and more complex. So to be able to achieve that aim achieved with those complex service users is a tough call. And to be able to deliver that within the 6 weeks is an even tougher call. But as I say, everybody's learning, and we're stepping up to that challenge. The other challenge is to reduce the overall average length of stay by expediting transitions into long-term provisions, and that means that we are dependent upon other community-based settings to be able to move the services that we support through bridging and reablement into those long-term provisions. I think we could do a better job in coordinating and forecasting that into the future, so that people get 6 weeks of lead time before they move across. However, we've got quite a few opportunities as well, and I guess number one opportunity is providing better transparency, forecasting demand, and collaboration through integrated digital systems. There are many different systems involved. Each care provider has a different system. The hospital has a different system. The GPs have different systems. So a lot of information flow goes on, and I think we could do quite a bit of good work around that. Utilizing AI-powered health and environment monitoring systems to monitor service users in their own services, so we could rapidly respond to any need that they have rather than the scheduled times that we normally go and visit. I think that would help with improving the care that we provide and reduce hospital readmissions. And then the last thing I would say, tighter integration and partnership working with community resources. I think that echoes the point that Eddie was making. Partnership. If we got like-minded people who have the same mission, then I think that we can do a lot of work to improve our delivery even further. Okay, so that was everything from me.
Fantastic. Is it over to us now, Gary, or do you want to add anything before?
I would suggest that we go to ask for the committee to ask questions of the presenters, Chair.
Brilliant.
I will.
Yeah, of course.
Chip in with your permission.
Oh, yes, of course. So even if the questions are directed at a certain person, if somebody else on the panel wishes to contribute, just let me know, because we want everybody's opinions. So that'd be very good. First of all, thank you both of you for presenting. Really interesting. I've learned a lot. I'm already filling up my pad with all this stuff. So I've got two questions, one for Eddie and one for G and Edward, and then I'll open up to the rest of the committee for more questions. I've got loads more questions, but I'll save those for if they're needed. Firstly, Eddie, I'm going to ask you the really big question. You're quite well integrated, which doesn't sound easy, so that's really great. But you want to deliver more, and also that graph you showed, we're in level 3 in the middle, which is actually it's in the middle, but actually it's good comparatively, but we want to get to level 4. So what do you think are your priorities for actually moving from level 3 to level 4? So from going quite well integrated to really well integrated?
I'm going to answer that by way of repeating something I heard today, which was we're in a place where I think organisationally we've got management joined up, some information joined up. We've actually got to allow our professionals now to get on with it a little bit. It's almost giving them the license, giving them a little bit of freedom and trust, so that the respiratory consultant in the hospital can break down some of the barriers with some of the CNWL teams and the GPs, and actually establish a respiratory clinic. In particular, this would be probably more in the north of the borough, but it's almost like you get the 3 people in the room and they want to do it, and it's almost now the organisations that are saying, well, hold on a second, we've got to ask some questions. So we actually think that we're getting to the point where instead of the managers, people at my level equivalent elsewhere in health have got to actually start stepping back and allow some of our professionals now to get on with things. We've created, we hope, an environment. We've created the teams, and we've just got to let go a little bit. And I think there's some of the things I've put up there. We've now almost got to say, right, what do you want to do? And behind the scenes, how can we make the money work so that you're the same people, we employ you, you want to work in a different way. You're not asking for more money, you're asking for it to be used differently. So to a large extent, it's actually about giving license to our professionals to get on with some of this stuff.
So that puts a question in my mind, which is another one of the questions I want to ask. I'm going to cheat and ask you 2 questions, and I was only going to ask you 1. But what motivates somebody who is time poor and is working in a specific way to actually do that? So obviously what we're talking about is a really potentially good system, but I know from my own professional life, it's not medical professional life, that I have to focus on what I need to do, and this other way of working, that if I had time to work with others to work it through, and which sounds really great, I'd love to do that, but I literally probably don't have time, or just if my boss is watching, just about have enough time to do what I need to do. So giving the professionals the sort of letting them run with it sounds really good, but would they have the time to be able to do that?
There's a resource bump, because some of the time then you're parallel running, if you like. Before you move the clinic and have the commitment from everybody to move the clinic out of hospital into the community, you're doing some in the community and you're duplicating in the hospital, so you have a resource bump. Some of the services that we've got demonstrate that 2-3 years down the line, you've actually got a net saving, and you started at a level of cost and commitment. You had a bump to overcome where you were learning how to do things and you had to double run to a certain extent, but you've now settled that down and you're at a lower level. So if you take our neighbourhood paediatric clinics, they've actually, I think, the longest running neighbourhood service. They've been running 7 or 8 years. We have the best performing paediatric service with the lowest waiting lists in the whole of London, all London hospitals. And so people like Jay Ganapathy invested a lot, and at that time didn't have a lot of support, did it through sheer will and determination, but that provides a benchmark, but also a business model. I can show that to an accountant and show that it ends up being cheaper, and I can show it to a healthcare manager and show, look, the outcomes are better. So although I said we have maybe 10 neighbourhood services and there are 140 odd services, those 10 provide a pathway for the others. So that's really important. So they're almost like, if you like, the trailblazers that demonstrate it's possible.
Thank you. Interesting. I'm going to ask one more question to G and Edward. It's around the AI opportunities. Obviously, AI opportunities is a buzzword that we hear a lot about. But so how realistic are those AI opportunities? Is the investment there to make them a reality? And do we think, what is the benefit that we really think those AI opportunities will lead to?
Thank you for the question. So you're right, AI is a buzzword and it gets folded into all sorts of stuff. We're thinking, from our perspective, there's two parts to this. One is sensors and monitoring environments, wristwatches and all that other kind of stuff. That's all very proven technology, but bringing it into a central hub where that information can actually be collected and utilized. So that's one, the environmental sensing and the patient sensing. But the other part of it is forecasting, because we're sitting on a reservoir of data now that shows what kind of prognosis services come in with, what kind of diagnosis that they have, what kind of needs that they have, and how long it starts taking to be able to show recovery. So with all of that information, I would imagine some clever people than I could get their heads together and start utilizing that data, because when we're talking about thousands of service users, and we've just talked about the last year, we've been doing this for 3 years now, it starts showing patterns of data. So we're thinking to ourselves, actually, that kind of information will be gold to enable the professionals to interact and intervene at the earlier stages rather than the later stages. And the key to this is that 6 weeks, because actually if you miss a week, you're already going to overrun. So really the decisions have to be made as early as possible, and this is when I was referring to the ability to forecast. So I think it's got like two use cases.
So who's making the investments to make that a reality? Because obviously with all technology, investments need to be made in order to do that. So, Gary, did you have your hand up?
It was heading in that direction, Chair. I think the whole point about the technology-enabled care offer is really important and links in very much to what Adi was saying, and provides an opportunity to enable colleagues within the neighbourhoods to prevent escalation of need, and that's precisely what we'll be coming back to the committee with to your July meeting.
We will cover that more in depth.
We will cover it more in depth
in July. But just to quickly finish, but obviously, are you interested, as is Comfort Care interested in doing its own sort of work in this area, or do you are you relying on a lot of other partners to do the work in this area?
So we're very, very lucky because we've got a partner that does a lot of software development for us and stuff. But there's a lot of ethics around data usage and stuff that we have to respect and we have to honour. So this will definitely be a partnership with the council when we come to that. But our prototyping work we're already doing on there to be able to develop the framework. Into this. We want to use the data that we've got, and with the recent government announcements of adopting AI right across the public sector, I think it is a really good time to deep dive into this opportunity.
Great, thank you. We'll come into that a lot more in a future meeting. So, Councillor Nelson.
Thank you, Mr. Chairman. And this, Eddie, is a couple of questions to you under the neighbourhood working in action. And the same-day urgent care, you said that was established. How has this impacted on individuals going to A&E? Because within the care package that you provided, it's supposed to stop that. But have you seen any changes in regards to the impact it's having, especially in Hillingdon near A&E? We've got quite a big problem with people waiting in A&E in admission.
Yes, we have actually seen an impact. I think I'll have to get back to you on the exact number, but I think it's something like 25 or 30 patients a day Wait a minute. No, let me get back to you on the precise number, because I don't want to go on the record and get an actual number. But the answer is yes, and we actually had to report into the ICB in terms of the improvement. I think one of the issues actually in the ED has been that the acuity of patients has actually gone up. So the ratio of the number of patients getting admitted, through the UTC and the emergency department has actually gone up. So we've got another issue there, that whereas the numbers of attendances has gone down a touch, and we would claim some of the causal impact for that, the actual numbers of patients getting admitted hasn't gone down, and that's partly to do with the acuity levels of the attendees going to the ED. But our UTC, since it started, is what you call an inflection point, where the same-day urgent care started and the numbers started to decline. Yes.
I've got more than two, but I'll just do the next one, and then...
Do the next one, then wait for everyone else, and then if it hasn't been asked, you can come back in at the end.
As well as the existing neighbourhood management team, you have identified priorities for particular focus, and you said you expanded on in favours across the borough and the benefits to both sides. But you did indicate that one side is much more prevalent than the other. Can you explain what the meaning of that is for me, please? The benefits of the service provided on both sides, the north and we say north and south divide, but you got the north and then you got the south divide. That is more density of residents than the north side of the borough.
Sure. Sorry, beg your pardon, Mr. Chair. So what I'm saying is the emphasis on the areas that the neighbourhood teams want to develop is different dependent on the local population. So in the southeast, there's a much more diverse population, a younger population, a more transient population. They deal with more younger people's anxiety and depression. They deal with both adult and younger people's obesity, diabetes as well, which are obviously there's linkages there. So, and in terms of emphasis, when you're in the north neighbourhood, there are some of the same things. Hypertension is a very significant issue and long-term condition across the whole of the borough, but there's there's higher percentages of elderly patients, so elderly people's mental health, dementia, falls and frailty are more of an emphasis in the north of the borough. So there are very many long-term conditions that are common. Well, they are common across the whole population, but because the population profiles are different, the emphasis and what the community, the teams and neighbourhood teams are working on is slightly different depending on their local population. Does that help? Does that explain it better?
I needed to get an identification of both the north and the south and why you say what you said in regards to that.
Right. Yeah, thank you.
Thank you, Councillor Nelson. Councillor Chandal.
Thank you, Chair. Thank you both for your presentation. Gee, this is more for you. I get the intermediate care hospital bridging reimbursement, but you said you get 20% from the community and they're quite complex. Can you just elaborate? Excuse my ignorance if I don't know where the community referrals are coming from.
Yes, I will ask Eddie to comment on that. But basically, it's it's just broadly the community on there. So the referrals do come through adult social care directly into our bridging, reablement services, and it's really the first stage before, and it's a alternative to referral into the hospital kind of arrangement. So it's a preventative exercise rather than actually recovery directly. Does that answer your question?
Through you, Chair. Yes, and that then would affect the figures going into A&E as well, then, wouldn't it? Right. Because if they come straight to you.
Yes.
So
if they can be enabled and supported in the community through reablement, then it prevents referral into the hospital.
Lovely. So it's a win-win situation in a way. Thank you.
Gary, you had your hand up. If I may add to that, Chair, I mean, what we have seen this year is a 60%, approximately 60% increase in the number of referrals from community going into the reablement service, and that is all about an emphasis on prevention, so preventing an escalation of need, which could then lead to those residents not only losing their independence or having a reduction in their independence, but actually ending up in hospital.
Okay, thank you. Councillor Cawthorne.
Thank you, Chairman. Wonderful to hear about all these developments this evening. All very familiar ground to me, of course. I've got probably two questions. I might the second one might be a slightly bigger question, but I'll try and limit it to that, Chairman. And the first one's to you, Eddie, really, if I may, and it's around this neighbourhood model that you're talking about. It's not new, as you say. It's been around for a long time. And listening to what you're talking about, I'm kind of thinking of the Dutch Buurtzorg model of care, which I imagine you've come across. It's one of the key components of that is the degree of autonomy that the clinicians and practitioners have in making judgments about what's an appropriate level of care and support, working very well in improving outcomes. I just wonder to what extent there are similarities between that, because certainly a characteristic of the way our system works is organisational barriers and constraints stand in the way of working effectively together. And I'm just wondering to what extent that model is part of what you're talking about. Is that a long-term aspiration? Is that where we are at the moment? Or is it not even on the agenda? I do actually have a second question, but shall I leave it there for now? Yep.
Yes, let's go with that one first, and you can come back with your second question.
So, I'm embarrassed to say I don't know the reference to the Dutch model. So apologies for that. I have to say that as you've described it, I would imagine there are a lot of similarities. One of the concepts about neighbourhood working that we are trying to make a reality is that a neighbourhood should be small enough that you have relationships with people across organisational boundaries. So it's small enough so that you don't require a standard referral process, but you can actually talk to a social worker, a community nurse, a mental health practitioner, if you're a GP or a social prescriber, because you're actually working in teams that have relationships. And within that, then you do empower people to be able to make decisions between 2, 3, 4 people around the patient, rather than go through a referral process, fill out a form, send it somewhere, and hope that you've sent it to the right destination. So it should be empowering, as I think I'm hearing you describe. Yes.
Thank you.
Yeah, if you want to ask your second question.
I will. Sticking on with the subject of autonomy, because I think that's important. The first bit of this question is really, addressing really to all of you as parts of the health and social care economy, if I could call you that. And it's this idea of how we work together, the extent to which you can informally make suggestions and innovate in terms of what you do if you spot a gap in provision or an opportunity to improve a service or an opportunity to make a deficiency. I'm just wondering whether our ways of working lend themselves to doing that well without recourse to sort of formal sessions like this where we're bringing you informally to ask you questions. Do you have a working relationship between yourselves, social services, and the wider health partners to actually, on a regular basis, as a matter of routine, look for improvements all the time? Is that something you do? And if I may, just as the extension to that, and this is specifically to comfort care, and I remember meeting you at Parkview some years ago, didn't I? As part of our commissioning arrangement with you, to what extent are you able to, I suppose, add value and innovate, drawing upon your own organisational knowledge from elsewhere, to the work that we're talking about this evening? So I suppose they're my questions. Thanks.
So if you want to go first, and then the panel can more broadly open up about our sort of learning and working together.
In terms of the first part of the question about is a system configured to allow for partnership working and things of that nature, I would say no. The system is not configured that way. But there are a lot of passionate people who are wanting to overcome these barriers and now reconfiguring the system to allow for that work to go on. So I think just normally, as any normal organisation would be, they'd be in silos, and I think people are finding the value of it, and certainly ourselves. This leads on to the second part of your question, Councillor. How shall I put it? We work together and then ask for forgiveness later. So people really get up every morning. I believe this. They get up every morning, want to do a better job. And I think Ed mentioned it in a slightly different way, which is actually, if you just get out of the way, let the people who know what they need to do work together, and just have a supervisory role to make sure everything is safe. I think then that way it creates connective tissue between partners, and before you know it becomes the norm. It becomes normal working. And in answer to your question about commissioning, there is a specific line in all of our contracts that talk about innovation and that the expectation of that innovation. I think there's lots of contracts that get signed that people don't put a lot of effort into completing each one. But if you have a recipient, and in our case it's a council that actually commissions us, if you have a recipient council that is actually encouraging that all the time, then it becomes really very easy to do that. So that's a long way of answering that. Formally, probably the structure isn't ideal, but there are a lot of willing people who want to actually do a good job, and they actually get on to do the job. And as long as the senior people like us can stay out of the way, encourage them, and just have a light type supervisory role, it works better.
I really don't hope you only talk when you come and see us, because that would be a real shame. But Gary, as the sort of council and the commissioners of the services, I mean, what do we do to make sort of communication and experimentation something that our partners feel like they can do?
We work very closely with our partners, and I have to say, I think Comfort Care has actually been quite innovative in the way that they've approached something, and some of our key partners have been very adaptive to changing circumstances, which again is something that we encourage. And I think is also it's part on our part about not being too prescriptive, allowing partners to actually identify solutions to problems which they manage to identify because they're dealing with the situations on a daily basis.
Yeah, Jan. Yep.
Just to carry on from what Gary and G has said, our partnership working is very much about an open conversation. We meet on a regular basis, not just as a senior management team, but also from our operational teams to work through problems, and that we only get involved when they can't resolve it, but we have those open conversations, and there has been collaborative working, and that's what we've always built our commissioning on, is that we want to have those partnership working relationships with all providers in Hillingdon. We have our key partners, our lead partners, and Comfort Care is one of those. As G said, we have a number of contracts, but there are other lead key providers that in times where we have that demand, we can pull on our resources to actually work out how we're going to work forward, and then we come up with our solutions that come into longer term solutions or short term solutions, and it's very flexible. It's a flexible approach and a flexible working partnership.
Chair, if I might just add, a really simple example is actually where Edward and team work, which is literally in the Civic Centre. So they're embedded. Now, when we were originally commissioning, or we were being commissioned, there was a big dialogue around this, and one of the reasons why we wanted to do that is not only just to be close proximate-wise, but also the innovation piece, allowing immediate decisions to be made. And I think it really worked wonders through the pandemic period, and it just became a habit of working closely together, where senior people and all levels of people can just walk across and start working with each other rather than going through those formal processes and routines. I mean, as a head office, we're not very far away. We're only in Slough, but really you can see the dynamic engagement because of the proximity piece.
Slough feels far away.
Often does.
Civic Centre definitely sounds a lot better. Thank you. Councillor Bells.
Thank you, Chair, and thank you for your presentations. Just questions for Comfort Care, really. When you have your staff leaving, how does that unpack on the service delivery?
Luckily we don't have too many staff leaving. Our retention rate is pretty good on there, but because of the nature of especially in reablement, where it is just a 6-week period, it means that actually if a staff does leave on there, the service users that they're particularly supporting doesn't have that experience for a very long period of time. It's not like long-term care where the same staff member is supporting an individual for maybe months or years on there. But that said, it actually does have a detrimental effect on the overall knowledge base within our service. So we'd prefer people not to leave, but there is a free world, and the only way that we can really deal with that is either attract them to retain them, or actually the new staff develop them at an early enough stage so it's seamless for service delivery. So our preference would be that they wouldn't, but it is the reality of it, so we can only just mitigate the impact.
Thank you. And with the population of the borough going up, as we all know, and the budget squeezes that are going on, is there a limit of what you can deliver? Because I notice your arrows are going up, you're seeing more and more people. Is there going to be a squeeze? I mean, maybe not for you to answer, but maybe is there going to be a squeeze one day?
I think just on the theory of it, yes, there will be, but I think there's enough opportunity within the current system of improvements to be made that actually we can squeeze more out of the system. But there's going to be a natural cap. We haven't reached it yet. And where we did reach it, maybe, I think it was probably coming into this winter just gone. I think it's just an open dialogue with the council. And Jan and Gary give us a hard time about wanting more for less. But look, ultimately, we all have to pay the taxes. We have to get value for money, and we understand that piece. So the innovation, the technology discussion, everything else is about squeezing more for less, and I think there is an opportunity to do that. But in direct answer to your question, I think there is a theoretical limit, we just haven't reached it yet.
Great, good stuff. Okay, well, you've been with us for over an hour, so I want to thank you all for a really interesting presentation, and we learned a lot. I imagine what we'd want to do is once we start thinking about recommendations and all that sort of stuff, we might want to run them past you just for your comments and your views, and we might want to come back on certain things. But of course, if you have any ideas and you think there's anything of interest to us, do send it to Nikki and she can share it with us. But thank you very much. And you're free to leave. But do take the cake. The cake was good. I ate the cake. And I can highly recommend it if you like cake. But we'll carry on with our meeting, so thank you very much. Okay. Okay, so we're going to move on to item 6 now, which is Budget Spending Report Select Committee Monitoring. And this is a verbal update because I just wanted to inform the committee of some sort of constant work that we'll be doing over the next year, I imagine. Obviously, we were all at full council, so we all understand that, and Councillor Bell's alluded to it, certainly during the last item, that finances are tight and savings need to be made across the piece in the council, but also we need to meet our statutory duties, especially in adult social care, but also as well we need to deliver good services to try and stop people from needing more serious support if we can help them earlier. So what we're going to be doing from now on is each meeting we're going to be having an agenda item which is titled Budget Spending Report, and this will probably start from June in reality, but we're going to have a paper essentially from the finance team which will probably have 4 bits to it. A financial summary which will include total expenditure to date and savings achieved versus target. Then we'll have a budget overview section which is expenditure versus budget and budget variances. Then we'll have a saving progress item which will be savings achieved against saving target. And then we'll have last one, risks and mitigations, so key risks and mitigating actions. So that should give us information to delve deeper into what's going on, and if we pick out specific issues we can go deeper into those issues. So it's going to be a sort of new thing for us as a scrutiny committee to be doing on a regular basis, but I think very, very important. But what I would like to do for April's meeting, I know April's meeting is very busy, but this is very important, is I would invite officers to come along and talk to us about how the health, adult social care and public health budget works, in terms of how issues are monitored and escalated, also in terms of some of the savings that being made and how those might be made, and to talk maybe in the past about if budget overruns have happened, why have those happened, and for example, what do our statutory duties really mean to us in practice, and all those sort of things. And I think that will be a really interesting meeting for us to sort of think about these things before we get into the actual monitoring of the actual budget and savings and targets for the next year. So I just wanted to let the committee know that's going to be a future work stream for us. So we'll be talking a lot more about this stuff. Okay. We're all happy to move on to the next agenda item? Brilliant. Thank you very much. Right, so the next agenda item is the Cabinet Forward Plan. Does anybody have any comments on the Cabinet Forward Plan? No? Are we all happy to move on to the next agenda item? Excellent. And the next agenda item is the work programme. I have no comments because I think it's in a good state at the moment. Obviously, I've talked about adding the budgeting, spending report. Does anybody else have any views, or are we happy with the work plan as it is at the moment? Happy as it is? Fantastic. So, I call this meeting to a close then. Thank you, everyone.